And welcome everybody. Good evening and thank you so much for joining us tonight. I'm Leslie and I am the president of the newly chartered Northern NJ Chapter of the Hospice and Palliative Nurse Association. I'd like to welcome you all and also give a very special welcome to our sister chapter of HPNA from Arizona and everybody from around the country. We have a great turnout. I want to say we have about 55 attendees, and this is great. This is really great. And I want to just kind of start off with a little introduction about what HPNA is. We are part of an organization that was established in 1986. And HPNA, it's a national professional organization that represents the specialties of hospice and palliative nursing. HPNA supports the professions through education programs, research initiatives, and advocacy. So before we get started, here's a few housekeeping rules. Just want to let you know this webinar is being recorded and a link will be uploaded to our website. All phone lines will be muted for the duration of the program to limit background noise. For optimal viewing, please make sure that you click on side-by-side speaker view on your Zoom view. You are welcome to ask questions by typing into the chat box. And I also want to make sure that we are clear that none of the content that's being shared with you tonight is intended to provide clinical or legal advice. On our website, we're going to post some attachments for your review. They include background information on caregiver burden, the Zarit burden tool, and a handout on how to request your CEs. So we'd like to thank the following co-sponsors for our first event. Norris McLaughlin Law Attorneys for their generous donation. New Jersey Healthcare Quality Institute for their generous donation. Rutgers University for providing the CEs for this event. Realty Excellence for their generous donation. And Valley Health System for the viewing of the film. And of course, we're going to have a big thank you to Dr. Jessica Zitter for being with us tonight. Dr. Zitter is well known to our community as one of the original rock stars of palliative care, and she is an advocate for how Americans choose to die in this country. Now let's get an idea of who's in attendance. We're going to take a poll, so please let us know who you are. A community member, physician, nurse, APN, social work, doula. We're going to put the polling questions up now.
This is such a great functionality that Zoom has on here that I'm using for the first time.
Yeah. We're learning as we go.
So out of the attendees, it looks like there's 53% of us are RNs, 27% are APNs, 4% community member, 4% social work, 2% death doula, and 2% physicians. It's a wonderful interdisciplinary crowd.
Great, great.
And you can go ahead and close the screen by clicking on stop sharing at the bottom there.
Okay, so I also want to share with you that you are all going to be entered into our raffle, which will be held at the very end of the program. We're going to be raffling off 2 of Dr. Zitter's books, Extreme Measures, Finding a Better Path to the End of Life. The NJ HPNA continues to build an inclusive culture that encourages, supports, and celebrates the diverse voices of our membership community. This will improve and innovate how we interact with the communities we serve. We value collaboration and invite all disciplines to join our chapter. The cost for a 1-year membership for nurses is $25. For other disciplines, the cost is $20, and we offer free membership to students. To those of you who donated while registering, your donation will provide funds to our newly created Dr. Jessica Zitter Fund, which is dedicated to providing education to our chapter members. And we thank you and we appreciate your support. If you'd like to donate, please go to our website. We encourage you to please join the HPNA and specifically our chapter. We currently have 27 active members, and we want to continue to build the New Jersey community. We need your input, ideas, and support. We'd also like to mention that our name, Northern New Jersey HPNA, can be a little misleading. We're actually the only chapter in New Jersey, and due to the new virtual world that we live in, we are easily accessible to all of New Jersey HPNA members. So did I mention that we'd like you to join? Our mission is to build an influential network of hospice and palliative care nurses and professionals in New Jersey, to share tools, resources, and education focused on the provision of expert care of the seriously ill. We recently conducted a needs assessment survey. You shared with us that the topics you're interested in are pain and symptom management, communication, advanced care planning, wellness, and self-care. Thursday evenings were your preferred meeting times, and you were more apt to join if we provided CEs and professional networking. We're working on getting more programs with CEs. In the upcoming year, we hope to present complex case study presentations, discuss journal articles, create a book club, and soon a weekend meditation retreat to recharge and de-stress. Now more than ever, we need to learn skills of self-resilience and self-care. Now I would like to recognize our team. Melissa Garrido, President-elect and Secretary. Ryan Murphy, Treasurer and Chair of our Membership Committee. Adrian Alate, IT and Social Media Chair. John Castleman, IT Planning Co-Chair. Lauren Parks, Fundraising and Membership. Donna Fahey, Co-Chair of Planning and Education. And Tacey Silverberg-Urian, Immediate Past President. Thank you all for your support in coordinating this event. It took a lot of work and a lot of time and commitment, but we're making it happen. So when you signed up for this webinar, I hope you took some time to click around our nursing network page. We'd like you to take a moment to read about us and get to know us. We're eager to meet you as well. And when it's safe, we're hoping that we can all meet in person. We even have a platform on our nursing network page where you can post information. So moving on, let's go over for our agenda for tonight. We're going to start out by reviewing the objectives, and then we'll conduct a pre-program poll. Afterwards, we will screen the documentary. And then we will, I'm sorry, I just lost my screen. Afterwards, we will screen the documentary. We will have a fireside chat, and then we're going to summarize the program. Dr. Zitter and Shana Siegel will be participating in our fireside chat, and then we will also take some questions from the audience. So the objectives for tonight are going to be, hopefully we will be able to summarize the range of challenges faced by America's family caregivers and formal caregivers. We're going to learn how to prioritize the critical importance of identifying family caregivers and assessing for the caregiver burden in their practice, as well as discuss the strategies for supporting caregivers. Okay, moving on. We are going to, at the end of our session, you're going to receive a survey from Rutgers, and those who are interested in receiving 1.25 CEs will complete the survey evaluation. Your feedback is very important to us because we want to know what you'd like to see in the future, and we also want to know what you think of, our program and how we did. In 2017, about 41 million caregivers in the United States provided an estimated 34 billion hours of care to adults with limitations in daily activities. The estimated economic value of their unpaid contributions was approximately $470 billion. 1 in 5 Americans is caring for someone in need in their homes. They usually care for them for 4.5 years, 24 hours a week. They use up to 31% of their savings. 50% have no help. 60% suffer from symptoms of depression, and 67% don't go to the doctor for themselves. Caring for family at home provides emotional benefits, but it also puts caregivers at risk for emotional, physical, social, and financial distress, risks that are often referred to as caregiver burden. Evidence shows that most caregivers are ill prepared for their role and provide care with little or no support. Integrating caregivers into hospital discharge plans for elderly patients in need of long-term care significantly reduces the likelihood of hospital readmission. Nurses play a key part in effective discharge planning, which includes identifying the primary caregiver in the community, maximizing community resources, and identifying caregiver burden while collaborating with the interdisciplinary team. Nurses can now assess caregiver burden using measurement tools, such as the Zarit burning screening tool, and this will help develop interventions to support caregivers. So now I'd like to turn it over to Melissa to introduce the film Caregiver, A Love Story. And then she'll introduce Dr. Zitter and Shana Siegel, a New Jersey elder law attorney.
Hello, everyone. It is my pleasure to introduce our panel, Dr. Jessica Zitter, who is our friend and native New Jerseyan, author, speaker, and award-winning filmmaker, and advocate on how Americans die at home. She is a physician, double certified in palliative care and critical care. She's a writer. She wrote Extreme Measures, Finding a Better Path to the End of Life, an insider's view of critical care in America and its impact on the way we die. And she had authored multiple essays and articles that were published. She's also a filmmaker. She did Extremis, which is an Oscar and Emmy nominated, currently streaming in Netflix. And she did this Caregiver, A Love Story, which we're about to see today. And her third film on the works, which is titled The Chaplain of Oakland. She's a speaker who's sought after with audiences from healthcare professionals, family caregivers, national organizations, and other groups. She is a graduate of Stanford University and completed her residency in internal medicine at the Brigham and Women's Hospital at Harvard University Medical School. She completed fellowship in pulmonary and critical care medicine at University of California, San Francisco, and earned a master's in public health from UC Berkeley. So let's welcome Dr. Zitter. Our next panelist is attorney Shana Siegel. She practices in the area of elder law, specializing in representing seniors, specializing in life care planning, public benefits, trust and estate planning, and long-term care advocacy. She's a certified elder law attorney in Northern New Jersey, certified by the National Elder Law Foundation. She's the past president of the New Jersey chapter of the National Academy of Elder Law Attorneys. She's a member of the New Jersey Women Lawyers Association, the New Jersey State Bar Elder and Disability Law Section, and the Life Care Planning Law Firms Association. She was invited to join NILA's prestigious Council of Advanced Practitioners. Welcome, Attorney Siegel.
Thank you. Glad to be here.
Okay. And I also like to thank my very own Valley Healthcare Systems for sponsoring the screening of this film. So the film that you're about to see, Caregiver, A Love Story, tells the story of Rick Tash as he cares for his dying wife over the last 9 weeks of her life. Rick is one in 53 million family members caring for sick, disabled, or dying loved ones at home, and witnessing his experience up and close and personal we begin to learn about family caregiver burden. This is a rising public health crisis that is affecting 1 out of 5 Americans. Before we begin the film, we invite you to reflect the 6 statements and answer them so we can take and share a real-time poll. Also, after watching the film, you will have the chance to confirm, change, or expand on your responses. So we're taking a poll. So let's take a poll now. Well, it seems like, there's still people answering, but it seems almost like unanimous. The answer is better for a person to live at home, 51% or 100%, 52 out of 52 currently right now. The second question, it's our duty to care for a loved one at home. Agree is currently at 69%, disagree at 31%. Family caregivers get a lot of support from hospice, 57% said agree, and 43% disagree, so almost half-half. Number 4, strong family friend and community relationship make caregiving a lot easier. 94% said agree and only 6% disagree. Question 5, there are a lot of formal resources and support for family caregivers. 20% agree and 80% disagree. And the last question, I've used the Zarit assessment tool to identify caregiver burden. Only 15% agree and 85% disagree. So also, when you watch this film, please make a note of some of Rick's challenges. Were there missed opportunities where these institutions or people around have taken more of a load of Rick? You can write that down so we can discuss it. So without further ado, let's watch the film. This is Caregiver, a Love Story. Wow, that was an amazing film. No matter how many times you watch that film, it's a resounding tale of what we experience when it comes to our dying patients and our challenges when it comes to caregiving. So I'm sure you were able to identify some missed opportunities. Let's take a deep breath and breathe. We'll now take the poll again from, this is an after poll, the same poll that we did prior to the movie. We'll ask the same 6 questions. And let's see if there are any difference with your answers. Majority of you for question 1, again, just like the first, prior to the showing of the documentary, it's better for a person to live at home, and 92% as opposed to disagree, which is 8%. Second question, it is our duty to care for a loved one at home. It's still, this is the question that's almost the same from the first one. Agree is 55% and disagree is 45%. The third question, family caregivers get a lot of support from hospice, and 51% answered, 22% agreed, and 78% disagreed. Strong family, friend, and community relationship make caregiving a lot easier, and 75% agree and 25% disagree. The fifth question is there's a lot of formal resources and support for family caregivers. Agree is now only 2% and disagree is 98%. And the last question is I plan to use the Zarit assessment to identify caregiver burden. There's 67% and disagree is 33%. And we'll learn more about the Zarit assessment tool later on in the program. So now I'd like to turn it over to the panel. Lesli will moderate the discussion and learn why Dr. Zitter decided to focus on the caregiver in this film, and Shaina will highlight some of the missed opportunities. Lesli?
Thanks, Melissa. That is a very powerful film, and it's it brings me back to when my grandmother was on hospice at home. And, it's tough. I always tell my families, home hospice is not for the faint of heart. It is a challenge. And if I could just, identify with that, it's a beautiful thing, but it's a tough thing. So, we're going to chat a little bit about the film. And I do want to start off with a couple of questions for you, Dr. Zitter. I know that you've said that this film was the first time that you really understood the crisis of family caregiver burden. Can you elaborate a little bit about that for us?
Well, I'm not proud of it. First of all, can I just do a quick shout out to all of you, amazing nurses and other professions, and Pat Murphy, who is the person who started it all for me. Hi, Pat. So good to see you. Pat is the person who really, when I was at UMDNJ as a new ICU doctor, brought me into the very nascent field of palliative care medicine, kicking and screaming, I might add. Hi, Pat. Hi, David. Anyways, I just wanted to give a big shout out of thanks. So yes, this is a shocking and slightly embarrassing thing to admit to, but I have lived a lifetime of profession of acknowledging my shortcomings, and this is one of them. I'm a palliative care doctor now since, Pat reformed me and I became boarded in palliative care medicine in 2008. And I really thought I was doing a pretty darn good job at being patient-centered and sending people home to hospice who otherwise would not have had that opportunity. And this was the first time that I actually saw what happens outside of the hospital walls when people go home on hospice. And I want to tell you that one of my biggest concerns in making this movie was the potential for throwing hospice under the bus, because I still love hospice, support hospice, and believe in what hospice does. Bambi would never have been able to be home without hospice. The problem is we have misconceptions about what hospice is there to do and not to do. And I think most people on this call realize that. But it took me bringing a camera into the home of my friend, expecting it to be a different story, expecting it to be a story of success and a beautiful end-of-life experience, and we did it right, etc. And then seeing what happened really after Bambi had died in the post-production of this film and editing the story and saying, oh my goodness, the story is about Rick. The story has to be about Rick. I thought Rick was just the secondary character, this guy who was going to open the door for hospice in the film. I didn't think Rick was going to be, it was Bambi. She was this incredible, you saw her. And I realized it was really about Rick and the 53 million other family caregivers just like him.
Yeah, thank you. And it's, like I said before, it's amazing how we don't realize the importance of hospice, but also the limitations. And this film definitely shed light on that for us. Another question.
Yeah.
You were involved in the production of another film, Extremis, about 4 years ago. How do the messages of these two films differ, and how are they the same?
I'm really glad you asked that, and it's very timely because I am actually going to be sometime in April doing a program at St. Barnabas in your neck of the woods, which I pitched to them as a double feature of the two films together. And so I have actually been really thinking it's going to be a 3-hour session for their healthcare providers about, essentially bringing narrative medicine, bringing storytelling in, and seeing if we can sort of have these two stories, which really seem very different, right? Because Extremis is in the intensive care unit. It's about decision making and, in extremis and in, end of life situations and drama, this and drama that. And here's Caregiver, a love story that's happening outside of the hospital, at home. And yet both of them, if you really think about the similarities of these two films, it's where the real learning comes, because they're very similar. They both, let me just give you a couple examples, right? In both of these films, people had death plans. Donna in Extremis, her plan, she knew she had this genetic illness. She knew that many people in her family had died on ventilators, and she knew that she didn't want to be on a ventilator. And yet she got put on a ventilator. We know this story. This is very common. And she almost got trached. And Bambi had a death plan. Her death plan was to die beautifully at home with hospice, which is what I had told her was going to happen. And both of those death plans got foiled. Why? Because our healthcare system does not know how to be holistic, to think big picture, to look at all the players, all the social determinants, all the decision making and the communication, and we don't think about these things. We're all sort of in this focus of either in the intensive care unit, I got to keep those lungs ventilating, or in the home hospice scenario, I've got to, focus on keeping Bambi comfortable. And we don't sort of step back. And I do it more than, this is part of how we function because we're so exhausted, we're so desperate. We take our little job and we do it, and hopefully we do it well. But the problem is that sometimes it requires a whole interprofessional, higher level holistic approach. And we don't have that yet in this country.
Yeah. We're learning though, right? We are learning.
Well, I'm speaking to you. You're nurses and social workers. You guys are I should be speaking to my colleagues. Those are the people that need to, and the hospital administrators and the politicians. And this is a big systemic problem.
Yeah. I hear you. And, I just want to kind of allow Shaina to participate a little bit. I have a question for both of you, but Shaina, if you want to start, now that we've learned about this caregiver issue, how do you think we can improve the experience and the lives of family caregivers?
Well, thank you. I think that social workers and care managers in particular can really play a huge role in educating the caregiver in terms of what to expect. And of course, caregiver support groups can be really, a huge part of that. I think that if Rick may have had known a little bit more about what this journey might look like, that he might have been able to get more help to be able to prepare. I think he really needed more help from family, from friends. It's great that people want to come visit, but a visit isn't really what he needed. He needed somebody who could help, and then he could step out. It's so frustrating for me, the finances of it all, that, Medicare's coverage is so poor. Medicaid might have been an option here. Obviously, without really knowing more about their situation, I think a lot of times people don't know that Medicaid can be an option, and, for VA, for people who meet those criteria, can provide some additional assistance that would allow the caregiver to get out of the home and, get that break. What he's talking about, those 3-4 hours a day, Medicaid could, in the appropriate situations, provide that. Of course, the coverage is, the financial rules are terrible, and that's very frustrating, but something that obviously I help families address.
Yeah.
It's a political problem. We really need to change the healthcare system, but
Definitely. It's funny because I noticed earlier on in the film when Bambi said, everyone is here now, but in a couple of weeks when everyone is gone, that's when the challenges are going to be, really presenting themselves. And it's true, just knowing from being in that experience how everyone rallies around you in the beginning, but then as people's lives go on, it definitely does change.
Absolutely.
Yeah. So, Dr. Zitter.
Well, I was just going to say, and the other thing that's really important, Shane, everything you said was spot on. And I think, I saw in the chat, I'm sort of catching a few things here and there, but someone said there wasn't respite available. Actually, there was respite. She did go to respite for 5 days through hospice, but that was hospice respite. To have just general caregiver respite, Shaina could probably comment on this better than I, but that needs to be easily accessed. Right now, Medicaid does provide some. Rick didn't make little enough to get Medicaid benefits, so he's really caught in that donut or whatever you call it, in the in-between space. He's not poor enough to get support from some of the Medicaid programs. It varies state by state, but he's also certainly not wealthy enough to in any way hire any help and support. But, oh, I was just going to say something and I'm completely forgetting. It slipped my mind. It'll come back.
So now for you, Shaina, as we watch the film, we clearly identified Rick's physical, emotional, and financial burdens. Can you share with us, based on your expertise, how the healthcare system or the families could have avoided or minimized the caregiver burden?
Well, I think we've touched on that a little bit in terms of, seeking other resources, in terms of respite, in terms of potentially Medicaid. A lot of times people think that they're not eligible when in fact they really can be in many situations. A lot, they did do, as Dr. Zitter said, they did have a death plan, but I think understanding more upfront and having more conversations along the way can certainly sometimes help in terms of modifying that plan. So, in terms of an example of, people, she said she wanted to last until the grandchild was born. And that might be something that would be incorporated into something like a POLST. I'm sure all of you are familiar with a POLST document that then, there's kind of a permission of when it can be time, when it's time to go. But I don't know, I think it's so difficult because sometimes it's very hard to ask for the help that you can get. I mean, here they didn't have some of the legal issues that I often see, people who don't have documents in place end up having to go through, all kinds of legal issues at the same time. They fortunately didn't have that, but they were able, but they were still, and some of it, I think, it's that not knowing and not being willing to get the help that you need to really say to people. It's very hard to say to people, yes, this is what I need you to do to provide the support for me.
One of the things that we're really working on is this idea of like, what can we do? What can we do in the healthcare world? If we're in the hospital, if we're in the clinic, if we're hospice staff, what can we do to help people a little bit more? And I think what you said, preparation, because frankly, we don't have much of a social safety net in this country. And that is just a choice that this country has made and is making actively right now. Biden did propose quite a lot of money in the initial bill to support family caregivers. And this has been whittled down. And right now we're at a very, I don't even know where we are, honestly, right now. I think now we're at least less than a quarter of what he originally proposed. But I do think that even in the setting and in the face of this inadequate social safety net that we have in this country, and understanding that hospice, as wonderful as it often can be and often is and was for Bambi, is not in a position to fulfill some of the things that family caregivers need and shouldn't be expected to, by the way, because if we start blaming hospice for all of this, the hospice staffs really become more and more demoralized, and we need them to stay positive because they're doing God's work here. This is really important stuff. This is a very important interface. And they, if they're getting blamed for this, this is not a productive conversation. But I do think one of the things we can do is all of us in healthcare can acknowledge the caregiver, acknowledge this incredibly stressful, vulnerable job that they have just been thrust into many times not choosing it. And mention it to them and prepare them for the fact that they will need help. I think if people are given permission to see themselves as part of a group that will need help, they're going to be more likely to ask for it. There's a lot of shame and guilt when you are caregiving for somebody, in asking for help, in complaining, in anything that appears like you're not happy. So I think what we can do is normalize that, say you're going to need help, and start to help them strategize. I have a sheet that we give people: mobilize your homegrown help. Who can help you do 2 loads of laundry a week? That will decompress you a little bit. Who will help you? There's several things that can be done, that can be delegated, that could really take some of the load off.
Yeah. And I would say the other thing is after, right? I mean, he talked about how much, how hard it was after, and I've seen this with so many of my clients, and providing that therapeutic support that they need on an ongoing basis afterwards to deal with, you know, all of the now stress and guilt and, you know, trying to kind of transition back into their lives. I know that, and it was clear here that often that is really the hardest part is, okay, I've been doing this for so long, I don't know how to, you know, to not do it. And so that really, you know, providing that therapeutic, and in that sense that it can be covered by Medicare. That's, you know, one place where we do. I mean, there's huge inequities in our system in terms of what's covered and what isn't. And, you know, so I think we have to advocate for that, advocate for caregivers and the support that they need. They do save the system so much money. So it really would make sense for us to allow them to do it, because otherwise, you know, people are going to end up in nursing homes, and that's, you know, that's not the best, that's not what anyone wants.
Absolutely. And this whole, you know, rising movement of hospital at home, not even hospice, hospital at home, is very, very interesting. I've been looking at, and you know, you can imagine, fueled by the pandemic, of course, now with this exponential rise in the stress the family caregivers were already feeling, but to have COVID shut down adult day programs and to make it so that people couldn't come into your home and make it so that family couldn't come in and help and take over and give you, I mean, this is a tremendous explosion of burden that happened during the pandemic. But in a way, there's a silver lining, right? In that when you get this kind of pressure on the system, there have to be other strategies. And what I'm noticing actually in the literature is this whole hospital at home movement is really starting to say, we've got to support the caregivers. And there's a lot of programming. There's actually some Medicare demonstration projects that are starting to look at this, actual caregiver support within the hospital at home movement. And it's really rising since 2018. I've sort of seen more and more information about this. And I think that could be another approach to really helping in addition to hospice. Don't forget, it's a small percentage of caregivers that actually even have access to hospice, because most people aren't dying when they need support and when they're care recipient. So, you know, most people don't have hospice. So what about all those other people who are going to live for years, maybe decades, with their illness and still need support? The hospital at home movement might have something to offer here.
Yeah. Thank you very much. You know, it makes me think of the patients. I work in an inpatient setting, and I have a lot of patients who, though palliative care, the scope of what we could do is a lot different than what I end up doing in an inpatient setting. A lot of my patients are actively dying when I first see them. And we have a push to try to get them on hospice, even if they're only going to live for a few hours, because we want them to be able to have the families to have that extra caregiver support that comes with the hospice benefit. If nothing else, if the patient's own, you know, don't get to benefit from the other parts of hospice, at least the families can benefit from the bereavement support afterwards, because that's so important. We do try, you know, to utilize hospice in that way. So, so thank you both very much. A lot of really great insight. Now I'd like to see, Tacey was monitoring the chat for us. Do we have any questions from the chat?
There were a lot of comments around the conversations that you guys were having around, you know, lack of caregiving support, lack of reimbursement. Are there any plans for lobbying, you know, Medicare or Medicaid to pay for personal care versus care at a subacute level, which often happens? Are we moving the needle? I know that when I entered, you know, doing hospice back in the 90s, it was very different in terms of people really developing a language to speak about end of life. I think, you know, based on what I'm seeing is the needle has moved over the last couple of decades. We never really heard of articles being written. Now there's so many articles written in the New York Times, the, you know, Washington Post around end of life dying. And people are now, completing, I think more percentage wise, completing advanced care planning, but is the medical care changing? Are we doing less medicalizing of end of life care? I guess that's a question for whoever wants to answer it.
Well, I hate to be a pessimist. I hate to be a pessimist, but I, many of the themes that brought me into this work are still there. The hierarchy, the lack of interprofessional approaches, the lack of conversation and communication, whether it's among the healthcare providers before they talk to patients and families, or then when they're talking actually to the families, having coordinated messaging and sort of good communication techniques and approaches. I think there's more receptivity to it, and there's more of a sense that, yes, we need to do better. We're not, and there's, but, and so there, I mean, that's progress, right? The fact that we have palliative care in so many hospitals. I mean, when I first met Pat, we didn't know what palliative care was. You didn't know how to spell it. And Pat called it the family support team. We didn't know what it was. So now we have made progress. However, in the role as palliative care physician, I will tell you that there is still this very, very hugely steep hierarchy that happens between the ICU doctor and the palliative care doctor, the palliative care doctor and the chaplain. I mean, it's the hierarchy we all know about in healthcare, and it is incredibly destructive, and it leads to absolutely measurable problems in end of life and serious illness outcomes. I mean, I just don't. I know I'm preaching to the choir here on this call, but so I don't feel we've made the progress that we should have by now.
I see that, thank you, that Sandy Helby has a hand raised. Would you like to make a comment?
Yes, I am a nurse and social worker, and I've been in hospice for the last 33 years. So I've worked for quite a few different hospices. I think it broke my heart to hear the comment in the film, well, you can only have a volunteer for once a week, 2 hours, because Medicare doesn't pay us for that. And I think most of the hospices that I have worked for understood that that was something we were expected to provide, even though we didn't get paid for it. The hospice that I work for now is a not-for-profit. We have a foundation, and that helps us raise money to do a lot of things that a for-profit hospice probably is not willing to do, because they've got to put their money back to their investors. We don't have that pressure. But I do think that makes a difference. And it makes a difference in bereavement too, because Medicare says you have to provide bereavement, but it doesn't define what that's supposed to look like. And some hospices do very, very little. And some hospices provide really good support. So I think it depends. I put in the chat, my biggest anger, I guess, is that we have a for-profit healthcare system, that we're not going to provide anything for you that we don't get reimbursed for, because that just goes against the entire philosophy of everything. That wasn't really a question, but I had to vent.
And I just want to comment. I mean, yes, I couldn't agree more. And you should watch the proportion of for-profit and not-for-profit hospices, and the change in that proportion over the past 5 years is shocking. And I will not say that every for-profit hospice is bad, because I've worked with many that are very wonderful, and it really partly depends on the culture of that place. But I do think that there is a business motive, like there is in all of healthcare, and that just isn't. I don't think it's a good thing, but it is what we have. It's the system we have.
I have a comment, okay? It takes a village, Jessica. It takes a village. And this is the only industrialized country that ever has this problem. This would not happen in any other country. There would be care for their people until they die, and then some.
Yeah.
It takes a village.
This is true. I see that we can take a couple more questions. I see Summer has her hand raised.
I was just circling back to what Dr. Zitter mentioned earlier, that she hadn't really known what the experience was like outside of the hospital. And I think that as you know, hospice director of clinical services in the community, the patients come out from the hospital with an idea that they're getting from the hospital. No, the hospital told us you're going to bring the meds. No, we're not a pharmacy. We have to wait for the meds to be delivered. However, at the hospital, they do have a pharmacy. They could have discharged you with the meds. Like, there's just not very good understanding of what our capability is compared to an inpatient provider. And so, you know, I'm in a rural part of New Jersey. I'm down in Salem, Cumberland County, cover somewhat of the shore. And so across those areas, there's a vast difference between what meds we can local fill at a pharmacy, or what do we have to wait to be delivered from our provider. And so that first day, I feel like we're always disappointing the patient because they're coming out with an idea that they've gotten from the hospital, you know, whether it's the physician or the discharge planner or the case manager, and those people have no idea what we can actually do. But I don't know how to get them to understand what our capabilities are, because we are somewhat limited. It would be awesome if they could fill those meds at the pharmacy before the patient's discharged, so they're available as soon as we get there to do the admission. But that's just something we don't have much control over. And we get referrals from them, and sometimes they're dreadful last minute referrals. I have somebody leaving the ED right now that needs oxygen at home, and we can kind of make that happen. But the family doesn't know what they're in for. I wish there would be a little lead time where we could kind of prep them.
Yes, and you know, again, when you ask me what are the themes between the two films, right, Extremis and this, it's this fantasy-based behavior. The fantasy of perpetual life is the thing that keeps us intubating people and tracheing people and not talking about the fact that they're never going to wake up, or whatever it may be. And the fantasy of a good death at home is also a fantasy, that we are not being realistic with people about what to expect. And my social worker, who I love, I mean, she's not my social worker, but she's the social worker on our palliative care team, and she's actually on her way over here later because we're going to be doing the Sacramento Jewish Film Festival, if anyone wants to come to that public thing tonight, believe it or not. But anyways, she basically has been saying to me for about 5 years, we're getting too many bounce backs in our emergency room. And no, Jessica, you're not right. It's not because the family can't handle it. It's because we're not giving them support on the outside and they weren't prepared, and we need to do better. We need to do better at telling our patients. And I'm like, well, but wait a minute. This was 5 years ago. But wait a minute. If we give them too much of a, they're not going to go home on hospice, and we're going to scare them, and then they're going to want to go to a nursing. And, and the truth is, you have to tell people. You have to be real, and you have to be realistic and honest with people. Otherwise, just like with the intensive care unit, you're going to be putting people into a situation that they don't want to be in.
Mm-hmm. Mm-hmm. Yeah, I agree. Next, I have a question from Darlene.
Hi, my background is primarily pediatrics. I have done pediatric home care, some with palliative care, but my personal experience was in adult medicine, well, not with family. And my mom was in the rural Adirondack area where we could not find anyone. I mean, it took weeks to even find out if they were going to come out to even help us with palliative care. She had a mold set up, was taken to the ER. My sister was there because we were bringing in family to give my mom some time with everybody before she was going to pass. And she knew her time was limited, and didn't have her hearing aids, high flow oxygen, had a MOLS form that said DNR, also had me as the designated person, and the doctor refused to speak to me. My sister asked him to call me. And because my mom is hard of hearing and she tries to read lips and bobs her head, he took it as a yes and put her on an airplane and shipped her to Albany, which then we had to fight to get her back home 300 miles to be able to see her husband to say goodbye. He was in a nursing home. She made it home on a Tuesday, died on a Sunday. So it was hard the communication with the physician, and as far as respecting her, respecting speaking to the family members, and it's the communication. And she woke up in an intensive care unit 300 miles away from home, and she would not have said yes to doing that. And it was very hard, but we had a very difficult time. The communication with a primary physician, between him and the pulmonary physician was the one who helped us with the MOLTS form, but just the communication and listening to the family, and have that person having a designated person. It doesn't have to be a family member, but a spokesperson to make sure that their wishes. A lot of families don't have that set up. We started early. My mom they had everything set up right down to everything set up. And then that one step happened that crushed it all, but it was all about communication.
Sorry to hear that.
That makes me, that makes me think of Shaina. You know, how many opportunities do we miss to have these documents?
Yeah, it's and you know, and again, you did everything right, and yet you still had that. But you know, I think it's so important to have that, because if you didn't have it, then there would be no way, right, of getting, you know, what you wanted and being able to advocate. You know, I have had cases like that. I would say, you know, two things. Obviously, hindsight's always 2020, and may not have even had in that sort of rural setting. But, you know, I always tell people to work with patient advocates. You know, a hospital has an advocate, and that they can, you know, sometimes really make a difference. And I've actually brought emergency medical guardian actions in cases not that dissimilar, just to push. Obviously, no one wants to, you know, you don't want this to become a legal issue, but but obviously on the front end is, you know, you did it. You did everything that you can, and so, you know, that's just important to get those documents in place, have those conversations, and give your loved one the best chance that you can to make sure that their wishes are respected. We can never be 100%, but we can give them the best chance, and that's by having the documents in place.
Yeah.
So
Thank you.
We have time for a couple more questions. Do we have any other questions, Tacey, from the chat?
Nope.
No?
No more questions.
Okay. So I really just want to thank you guys so much for this chat. It's been amazing. The information that you're sharing with us, and you know, being able to show us the positives as well as the negatives in our healthcare system, right? Because we do a lot of right. We do a lot of stuff right. We do a lot of good, but also, as we know, you know, I say to my patients and families all the time, you know, I'm here to protect you from the healthcare system. You know, I'm here to advocate for you. And, you know, let's not do something to you that you don't want. So, okay, I don't know if,
Oh, you know what?
I do want to add
Lesli,
one.
Go
I'm
ahead.
sorry, Tacey. I just wanted to say, because somebody asked before, is it getting better? I do think, and Dr. Zitter kind of touched on this too, I do think that there is a greater recognition of the caregiver role, the burden, and the supports that are needed. And you see it, there's starting to be some funding, there's starting to be some legislation. So, you know, we just all have to keep pushing. So the more we push, and you know, the more it'll change.
Since we have a few more minutes before Ryan comes on, Dr. Zitter, if you could take a few moments, I'm curious to learn about your third documentary. Give us a little update.
Oh, I'm so excited to tell you. Well, let's see, where do I start? First of all, if anyone would like to get a copy of our newsletter, please do go to jessicazitter.com or go to info@jessicazitter.com and I'll send you the most recent newsletter, which gives you all of our activities that are happening right now. We're really excited. We've created a lot of programming around Caregiver Love Story for a variety of different audiences, caregivers themselves, healthcare providers. We have a presentation, and also hospice staffs. We're working right now on one, and one of the big things I want to do with this is to, number one, support hospice staffs with the moral distress that comes of witnessing this kind of powerful suffering and really not having the equipment and support to help them. So caring for the caregivers of the caregivers is the focus of this hospice program, and also helping people come up with some ideas for things that they can do in their local hospices based on case studies that we're going to show them of things that have been tried around the country to give people ideas of approaches that they can take in the hospice. But we've actually just started a production company, and we're just hiring for an executive director right now called Do No Harm Media. And there are many stories. I am a big proponent and believer in narrative medicine. I believe that showing people, bringing you into the home, up to the bedside, up to the bed rail of a patient and their family, and really getting this sense of what is going on for these real people in a both artistic and real way can help spark and make people emotionally primed to want to learn more about a topic. And we're seeing this with Caregiver. We saw it with Extremis. People become open to processing and discussing and reflecting. And I think even in the healthcare world, by being able to see yourself as a fly on the, being a fly on the wall in situations that you work with every day, which become rote sometimes, and we become numb, I think can be very helpful in sparking empathy and sparking a desire to kind of rethink the system that we work in. So for that, we are really going to start making more films. This next film that I'm working on right now is called The Chaplain of Oakland. And it, as I told you, Pat Murphy, who I hope is still on the call, is my first mentor. Okay, your first mentor for a doctor being a nurse says something about medical education. My second mentor is a chaplain. And Chaplain Betty Clark is somebody I have worked with for the past 11 years at Highland Hospital here in Oakland. And after I left Pat, I went and I found Betty. And Betty has been an inspiration to me in many, many ways. She is a 78-year-old African-American woman from Kentucky who came out to the West Coast in 1968 looking for a more progressive place, as we can imagine, than where she grew up. And she's had an incredible sort of professional and personal trajectory that I think is really inspiring in terms of becoming an activist. And she's always been an activist since she was very, very young. But she uses her activism now as a chaplain to really be a voice. Everybody has a story is Betty's tagline. Everybody has a story. And she has, over these past 11 years, really helped me to stop and to think about the fact that I, like many of us in our human brains, don't always stop to get the story, even when I think I'm stopping to get the story. And that this is all about this concept of implicit bias, and then it leads you to understanding about racial inequities. And of course, the area that I am particularly focused on in my work is end of life and serious illness. And when you look at there's racial healthcare inequities in every aspect of our healthcare system. But when you look at the racial healthcare inequities at the end of life, it's striking, and it's so easily explained. I mean, there's so many aspects to it, but what this film is going to do is it's going to bring Betty's words, it's going to bring us into Betty's life and her experience with patients, and her experience with physicians like me, white physicians, teaching, helping, providing a safe space where we can really start to examine ourselves and examine the system that we're working in ways that we may not have done had we not had this type of a person to lead us. And she, for me, has been that inspiration, and I want to share her. For this film, it's extremely important, since this film is going to be told through the eyes of an African-American woman, that it be a very diverse filmmaking team. And so I'm waiting. I can't tell you the name of this incredible director, but I'm hoping we're working on having her sign on to come in and co-direct this film with me. And the team will be a very, very diverse team. And I think, sometimes I think, well, I'm a white physician. Like, is it even my story to tell? But you know what? There is a part of this that is my story to tell, which is the experience of the white physician, the experience of the white physician who works in this work and thinks that we're progressive and thinks that we care and that we're kind and all of the things that we may be, but that if we don't really start to examine the role that we're playing and how we are part of the system, then we're never going to make any progress. So this is a film for a lot of different kinds of audiences, but I'm going on a lot. But that you can hear a little bit more about what we're going to be doing, and we're very excited about it. And if you want to learn more about it, please let me know, and I'll send you our most recent newsletter, which came out about 3 weeks ago, which has a lot of description about it. We're always looking for support. We're going to be creating a real impact arm for this film because we don't want to just make a beautiful movie. We want this film to have impact. We want to get it into every possible leveraged place that needs to see it and really start figuring out like what needs to change and how can we start to have some changes with to accompany this film. So we need you all to be part of it. We need you all to follow us. Please join our newsletter, follow us on social media, and stand by.
That sounds really powerful. But can you give us that email again? It's info@jessicazitter.
The best thing to do is go to my website, jessicazitter.com. That's the easiest thing. And in there, you can sign up for the newsletter, and you can find ways to contact us if you want to. We're there, and that's the best. Just go check out the website, jessicazitter.com, and you'll see all of the things that we're doing.
All right, so exciting.
Chat's disabled.
All right, so we're getting close to turning it over to, thank you very much again, Dr. Zitter and Shaina, for joining us. And I'd like to turn it over to Ryan. He's going to review the Zarit burden tool with us. And, there's really a more comprehensive survey versus what he's going to review with us is a tool. And it consists of 4 questions. And that's just for us nurses to be able to identify if there's an issue right at the bedside. So Ryan, I'm going to turn it over to you now.
Great, thank you. And thank you everyone for participating, and Dr. Zitter for allowing us to have this conversation tonight. So when we were thinking about planning the event, we really just wanted to offer something that you could take back to your practice and maybe just implement a small thing that can highlight this specific issue within your own family and patient population. So Tacey, I don't know, are you going to share screen just to get the slide up? Perfect. So we're going to talk about the Zarit burden interview. And like Tacey was saying, it originated as a much longer screening tool than it is now. It started off originally published in 1980. It was a 29-item self-reported scale that used 5-point Likert scale questions for caregivers to self-report about their different burdens in all different domains like psychological, emotional, social, financial, really trying to capture all of the different types of burdens that we see our families go through as they're caring for their loved ones. Originally, it was designed to target families caring for patients with advancing dementia. And over the years, it has been revised and adapted to become less cumbersome. I think it's funny that, it's testing burden or trying to screen for burden, and it was 29 questions long, and they noticed maybe that's too much for someone to sit down and do all at once. So there's been many different versions of different lengths, but each time they've done it, they've tested the reliability and validity against standard statistical analysis, and they found that it's reliable and valid. And it's also tested through time as well. Most recently into the 2000s, different teams have just checked to make sure that it remains valid and a reliable tool to use. And it's been translated to many different languages: Chinese, French, Japanese, German, Hebrew, Spanish, Korean, Hindi, and Portuguese, and has also been tested across different diagnoses as well. So you can see the one on the screen here is the Zarit 4-item burden. And you can see, again, it's a 5-point Likert scale where it's asking subjective questions. An example, do you feel that because of the time you spend with your relative that you don't have enough time for yourself? And that person would self-score from 0, meaning never, all the way up to 4, meaning nearly always. And higher scores are indicative of higher burden distress. And it's also been seen that the results are positively correlated with behavioral disturbances within their patients, as well as higher risk of depression for the caregiver. So again, we just wanted to offer something that maybe you could use, or ask your institution if they could look into using this tool when you're working with families, particularly in the home, to see if, we can formally, I think after this, hopefully we'll all pay attention to try to notice this a little bit more, but now this gives us a formal way, and maybe we can even bring those formal results back to our institutions or at a higher level to say, we have these results, our families are really under a lot of stress. What can we do to help them?
Yeah, I mean, even using it as a trigger, something that you do quickly for yourself with a family, or, a situation where you're not really sure if they're going to be able to make it at home. So you can do this and use it as a trigger to then maybe, consult social work or some other resource that they might be able to benefit from at home.
Yes,
So,
absolutely.
Yeah. Now,
before I throw it back to Leslie, I have one more job tonight, which is to announce the winners of the door prize. So I selected randomly through the participants. And again, we're going to be giving 2 copies of Dr. Zitter's book, Extreme Measures, Finding a Better Path to the End of Life. So we have Loretta Merengiello and Pearl Merriman as our winners. I believe that I'll be able to get your addresses, your mailing addresses from your registration, but if you have a preferred mailing address, if both of you wouldn't mind, you could chat me directly, and then you can just send me your mailing addresses and we can get those copies off to you.
thanks, Brian, and congratulations. Congratulations to our winners. So thank you all so very much. This has been an amazing evening. I want to thank Dr. Zitter and Shana Siegel for your commitment to and your advocacy for our families and our patients that are dealing with serious illness. As hospice and palliative care professionals, I always like to think that we can identify with everything that our patients and families are going through, because we're all at one point going to be caregivers, and we will all at one point be patients. So it's really important that we're able to bring this information and presentations like this to the forefront and start these conversations and continue to share this information so that we can be the best at what we do. So I want to thank you again, everybody, for coming, and hopefully we will see you again at our next event.
Great.
Thank you so much.
Thank you, everyone. Thank you, Dr. Zitter. Thank you, Shaina.
Thanks, everyone.
Thank you.
No, thank you.
Thanks,
Thank
Dr.
you.
Zitter.
Yeah.
So great to be here.
Mhm.
Thank you
Thank
very
you.
much.
It was great. Thank you so much,
Thank
everybody.
you, Adrian, you did an amazing job.
Yes.
I saw Annalisa came on for a little bit too.
Oh, did she?
Yes, but then she disappeared. She must have just come on for a bit.
Oh. Yeah, this was great. So now, Dr. Zitter, when you finish your next film, we'll have you on another event.
I would love it. That's going to be the first time that I really, really have planned impact before making a film, because I'm not making these films to just tell stories. I'm making these films to make change. And so you got to have a really robust impact program, and you've got to have people who believe in the film and who want to tell people about it. So you guys will be that group, joining with us and helping to get the word out.
Yeah, yeah.
Dr. Sitter, I don't know if you were here when they introduced themselves. So we have people representation from Arizona, California, I think Massachusetts, North Carolina. So there's a lot of people here.
Texas,
yes. Yeah.
What we would love is to get everybody on our mailing list. I don't know if there's a way to ask people if they're willing to join us, and let us put them on our mailing list. That would be a wonderful way to. Obviously, we don't want to do it for people who don't want to. So
we can ask
put it
them.
out to the registrants and offer it to them as give them the option. We can contact all of the registrants through the nursing network, and
that would be fantastic. We would.
Yeah.
That'd be so wonderful.
I'm super excited. This was great. This was really, really great.
Oh, you guys are amazing. Tacey, I came to Valley Health. You were there. It was Valley Health when I saw you all, right?
Right. It was me,
Yes.
Leslie, Melissa,
all of the same people. Great. I love it.
It was 2 years in 2019.
Oh, I wish we could do it in person again.
I know.
Oh, well, you should all come to the St. Barnabas thing. I don't know how easy it would be for you to crash it.
Are you doing it in person?
Oh, am I doing it in person? I'm sadly not doing it in person. I'd like to do it in person, but if you want, you can have me come and do it at your place. It's a double feature. It's a 3-hour program, and we will show both films and have a sort of a narrative medicine experience to really look at some of the themes that are sort of similar and different in the films, and talk about ourselves as healthcare providers and use it to reflect on things and come up with some ideas for new approaches. So,
well, you know what? I'm sitting on the HPNA's corporate DEIB task force.
Ooh.
And I think there's some intersection with what your message is and what we are also trying to transform our organization. So that might be good timing, for us to work together.
That would be great. We also have a program that's a much longer program. It's 8 hours. We did it virtually at a big hospital system here using the book, really, again, for healthcare providers, and sort of talking about just a reflective practice about the world in which we find ourselves working, and kind of giving us that sort of 30,000-foot view. So I'd love to talk to you about other programs that we could do together.
That would be great. I have to share that that I've been fortunate enough to have the residents at our hospital doing a 2-week elective rotation through palliative care.
Ooh.
And can I tell you how appreciative they are? They have no idea what we do. And then when they come and they sit in the meetings and they say, wow, this is what you do. Yep, this is what we do. And they walk away from that experience with, even if it's just one line of verbiage to get that conversation started. Yeah. So just the fact that, looking at that as an opportunity to bring something like this to, I kind of feel like if we can get them when they're baby doctors,
it's an interesting thing that you say that, because yes, I think one of the problems is that the rest of the healthcare culture is so, particularly in doctors, is really pretty unhealthy. And so when people do sort of see this one little place in the horizon where they can feel like a little bit more connected to their emotions and their moral compass, everyone wants to, well, maybe I should go do palliative care. And the problem is, we need people to be good surgeons.
Mhm.
We need people to be good psychiatrists, good ENT. You know, we need to bring this kind of primary palliative care philosophy
Mhm.
to all of medicine, not just lump it in palliative care. And that worries me a little bit, honestly.
Yeah.
But
Yeah.
you know,
I agree.
Mhm.
yeah. So
We're
Uh,
getting one
One,
resident at a time.
right, exactly.
one of the medical directors I used to work with in South Jersey, Dr. John Bertinoli, he taught at, I believe, Rowan Medical School. And every one of his students had to do a 6-week rotation with him. They had to come to our IDG meetings. They went on face-to-faces with him in the homes. They went on him with home visits to patients and had to see what end of life care really looked like.
Yeah.
And he had like 5 or 6 at a time, and they all had to cycle through him before they graduated.
That's got to be good. It's got to be good. That kind of experience has to be good. The experience of reading and doing narrative medicine has to be good. It's all about bringing us back to our emotions, our fears, our shame, all the stuff that's percolating around inside of us that keeps us in our little lane that isn't really humane, and really let us kind of take in a deep breath and say, no, let's connect again and let's do this. Let's do this in a different way.
I love that.
Yeah.
I love that.
Yeah.
I'm really thinking about, especially with your next project, trying to, focus on that, actionable piece, even like just kind of circling back to this event. And I'm wondering if when we're sending out, our recap evals and things like that, is there something that we could be asking participants to do? Or, what are we looking, how can we keep the conversation going? Is it writing to someone, or legislation, or within our own institutions? Like, what can we offer to everyone who is here tonight, saying, keep this going,
Yeah.
try this?
Well, it depends, because and this is what I'm finding as I'm putting this St. Barnabas program together. Like, what is the point of each program, right? This you could, the point of this could be, let's just make life better for caregivers. Let's try to figure out how to make things better for caregivers. Another completely resonant point with what we just did tonight and what we're going to do at St. Barnabas with the double feature could be, let's humanize the healthcare system. Let's bring our kind of consciousness and our moral selves to a conversation about how we want to behave. And let's see one, do one, teach one, in terms of not just putting in an A line, but like in terms of how we want to interact with people. And there's a lot of other see one, do one, teach ones that are all about humanistic principles, that if you see it and you see Chaplain Betty Clark coming in and finding out what the story is, and finding out that this person that everyone's calling a gangbanger is actually a mailman who got shot, just having that experience, I think, is mind opening. So you can get specific to how do you address caregivers, how do you communicate to help people figure out if they want to be on a ventilator or not, or you can have this be more of a sort of 30,000 foot view, like, how do we humanize the healthcare system? How do we bring our humanity back into this? Because we know that it for all of us, even the best of us, and I see myself, we get pruned. There's this thing about pruning and neurophysiology, that they prune down the unnecessary things. Well, what happens in healthcare, because we're so exhausted and we're so stressed and we're seeing so much suffering and we don't know how to handle it, is we prune down our empathy. And I really think that that's why so many people are burning out. I think
Absolutely.
just reconnect with the humanity of taking care of people. It just, does it make your day 20 minutes longer, even 45 minutes longer? Maybe. But does it bring you back meaning and purpose in your work, that I think so many of us feel like, oh, gosh, I don't have it. I think it does.
Yeah, definitely. I try to support providers, nurses, and providers, and tell them, palliating them and saying, you don't have to offer this. You could offer a conversation. We don't have to, give them a choice of something that's not going to be helpful, and giving.
Yeah.
I have found that giving nurses and doctors that space to contemplate not doing something is welcome sometimes. I mean, sometimes not, but
Yeah.
sometimes it's welcome. And they're like, oh, we don't have to do dialysis.
Yeah.
No, we don't. But it's that conversation, just like you said, humanizing it, you know.
Opening up for the uncertainty, and there's not a right and a wrong. This is all difficult and it's all uncertain. We don't exactly know what's going to happen to this person, but we have to make the best decision with the best information we have possible. And we don't exactly know if this person speaking for them is the exact right surrogate, and we have to sort of make our best judgment with that too. There's so much uncertainty and it's so exhausting, but the only way to make our way through all of this uncertainty is to have productive, constructive relationships where the neurosurgeon isn't yelling at the palliative care doctor. This just happened last week, and saying, don't ever let palliative care on my service. Don't ever call palliative care. You know, that cannot stand. That should be punished. That's not acceptable. When that kind of thing happens, even to someone like me who's sort of made a presence of speaking about this stuff, it makes me walk away with my tail between my legs and feel like, oh my gosh, maybe I am extubating people too early. I mean, this is not a productive way for us to communicate together. It should be kind and supportive and acknowledging of all of the uncertainty here. This is so hard, and there's no right answers. And when people act arrogant and sort of, you know, posture, it really makes everyone else back down, and it again creates this system where we're just on this conveyor belt and nobody is actually thinking about the patient and the best thing for the patient. Sorry, I just got on a
We are right there with you.
We're in the same tribe.
Preaching to the converted.
Thank you again.
Yeah, thank you so
Thank
much.
you.
Thank you again.
Bye, everyone. Thanks for
Thank
having
you,
me.
everyone.
Bye.
Thank you.
Bye.
Bye.
Bye now.
Thank you.
That was amazing. I
That
love
was really
that
wonderful.
we stayed on with her,
I know.
and we are recording it.
Yeah. Oh, should I? Yeah, we are recording it. When I can stop recording now, right?
Yes.
Yes.